what common psych overlap is there for adults and pediatric patients? For example, is depression, anxiety, PTSD, bipolar, or schizophrenia seen in these patients? And are narcolepsy and sexual drive part of this overlap?
Sure. So there's a lot in there. I think my first comment would be that mental health concerns and mental health symptoms are extremely common in the human population. So no matter what population you have, it's common to have anxiety and depression. Estimates in children have shown that mental health crises have dramatically increased over the last decade, and particularly in the last couple of years. And the pandemic led to an explosion of mental health to the point that it's recognized as a serious health crisis. And suicidality has risen to being one of the top 3 causes of death in teenagers in this country. So I say that because that's the stress of being a child and a teenager and a major component of pediatric health that we need to be aware of. In children who have any chronic health condition, there's always the increased risk of reactive depression, either with themselves or their families. In studies in multiple sclerosis, which maybe have gone on a little longer, there's good evidence that the mental health of the family influences the mental health of the child. So if a parent is depressed or anxious, that also leads to a higher rate of anxiety or depression in their child, and anxiety and depression run in families in general. I am not aware of any association between MOGAD and bipolar or early onset psychosis as a disease, as a primary psychiatric disease. The only thing I would add to that is that there are patients who develop NMDA receptor encephalitis who have had MOG antibodies or the other way around. NMDA receptor encephalitis is a separate disease than MOGAD, but it presents with psychosis and psychiatric symptoms as a core feature. So if you saw that in someone with MOGAD, I would be looking for NMDA receptor encephalitis.
I would agree with everything Dr. Banwell has mentioned, and my concept was anxiety and depression is either pre-existing in a patient or often reactive to a new and significant diagnosis, the implications of losing neurological function or their response to needing treatment for the long term in relapsing cases. And I think it's something that's very important that needs to be recognised and diagnosed and managed proactively because it really impairs quality of life. I would agree as well with the psychosis that it's the autoimmune encephalitis that I would think about. I'm not aware of studies linking MOGAD and narcolepsy. You mentioned sexual drive. I think in patients with myelitis and MOGAD, it's often the lower part of the spinal cord that can be affected, which controls also sphincter function, so bladder and bowel and sexual dysfunction. And while lots of patients with myelitis might have motor paralysis, that often responds quite well to treatment, whereas the sphincter function is quite slow to recover. So certainly a lot of adult patients who have myelitis, sexual dysfunction can be a long-term neurological sequelae.